All right, guys, so we are going to do a brief review of screening to prepare you for your pediatric boards here. So this stuff is the kind of material you've been learning all along Continuity Clinic. Just kind of want to go over some of the highlights for you guys. So there's a big table that the AAP puts out every year that kind of lists all of these, different ages to screen for different things. And what we've tried to do is really distill down for you, some of the highlights and things that are more likely to come up on the boards. So don't feel like you need to memorize this entire chart. The goal is really, again, just to kind of review some of the big ticket items that you're most likely to get. And you may notice some of these are a little bit different than what you're used to doing in Continuity Clinic. So I just want to point out some of those differences as we go along. So one of the first things that you're going to think about when you think about screening is the hematocrit. And most of you are used to doing this at 9 months and 18 months. But the AAP recommendation is actually to do this at 12 months. And again, a little bit different than what we're used to doing at PPC and Hopple Street, but AAP actually recommends 12 months. You want to do a risk assessment at around 4 months, 18 months, and 24 months, and then every year starting at age 3 as well. And the reason for that is to really screen for those kids who are drinking excessive amounts of milk, your breastfed babies who are not eating any meats. But the main ages you want to really screen are going to be 12 months is kind of your universal screening. You can either do hematocrit by a finger stick, or you can do a complete blood count as well, but the main thing you want to screen for is just the anemia. We also do another risk assessment for your teens, really ages 11 through 21 years old, and those are kids I especially screen for who have heavy periods, things like that make you worry about anemia. So just kind of something to keep in mind once you kind of get past that toddler age group. You also are used to screening a lot for lead, and AAP actually recommends lead screening between 6 months and 6 years. We typically do it at 9 months and 18 months at PPC and Hopple. The board actually recommends more around 12 months and 24 months screening in high-risk populations. So what constitutes a high-risk population? This is one that's always kind of tricky. For many of us, it really is automatic that we always just screen particular ages, but there really are particular criteria that you're looking at. So things that you want to keep in mind for kids that are at risk for high lead levels are kids who live in houses that are built before 1950. And keep in mind, this isn't just if you live somewhere, even if you're in a daycare or a school, or if you're in a home care provider, spending a lot of time there in a place that's built before 1950, that also increases your risk of high lead levels. You also want to worry about places that, if you get a history, there's a lot of peeling, chipping, dusting, chalking paint. House built before 1978, which has ongoing renovations. And probably the most key is to really worry about a kid who has a sibling or a playmate who has had a high lead level or lead poisoning in the past, or someone who comes in contact with an adult who has a hobby or works with lead. So if you have a family member that is involved in construction or welding, pottery, things like that tend to increase your risk of having a high lead level as well. So definitely you want to include those in your history when you're looking for possible high lead levels. Next thing I want to talk about is blood pressure. So you do a blood pressure, you're going to do a risk assessment from newborn to about 30 months at these checkups. So you're going to be thinking more about family history, things like that. The first time we actually check blood pressure is really starting at that 3-year checkup. And remember, hypertension is considered if you have a blood pressure that's greater than 95th percentile for gender, age, and weight. So remember, those are the charts that we take a look at. So there isn't a specific blood pressure that you worry about. As far as an absolute number to recall, you really want to use those charts to take a look at boys versus girls, age and height, and those are the things that you're going to want to use to determine what is the ideal blood pressure for these kids. If you have a kid whose blood pressure is elevated, you don't make that diagnosis at the first visit. You really want those measurements to be on 2 different visits, and have the kids actually come back in 1 to 2 weeks to get a second blood pressure. So that first visit, you're not going to diagnose high blood pressure. You really want to have them spread out over 2 visits. So vision is a pretty obviously common topic. We tend to get a lot of questions about vision just because there's a lot of confusion around it. So the most important thing you're going to remember with vision is you're going to want to start screening at age 3. So keep in mind, blood pressure is 3, vision at age 3. We screen the kids annually, ages 3 to 6, so 3, 4, 5, and 6. And then once we get past that, we go to every other year. And then for adolescents, we do objective testing every 3 years. So again, at age 15 and again at age 18. So what is going to constitute a normal screen? So for a kid who is less than the age of 6, you really want to have a vision screen of 20/40 or better. So again, less than age 6, you're fine for 20/40 or better. Once you hit 6, you really should be 20/30 or better. So keep that in mind. You never need to achieve 20/20 vision. If you are age 6 or above and you have 20/30 vision in both eyes, you're in good shape. If you're ages 3, 4, and 5, you want to have 20/40 or better. So how do you know who passed and who failed? So you want to refer if you're not meeting these markers, the goals I just talked about as far as 20/30 or better or 20/40 or better in the younger age groups. But if kids have 2 lines of difference between the eyes, you want to refer. So for example, if I am a 10-year-old and I have 20/20 vision in one eye and 20/30 vision in the other, they're both passing, but if you take a look at both of them, I have 2 lines in between because it goes 20/20, 20/25, and 20/30. So because I have 2 lines difference, then I'm going to refer. So let's say I am 6 years old and I have 20/30 and 20/40. Both of those are passing, and there's only 1 line difference between the 2, so that would be considered a pass. So that's the kid that you don't need to, worry about any eye pathology at this point. If you have an uncooperative kid, technically the answer should be rescreened in 6 months. So we see these kids starting at 3 years of age. We screen. Oftentimes what we typically do is have them come back just at a year, but for board purposes we really want to rescreen those kids and have them come back in 6 months. So just again, kind of summary for vision, you want to start doing formal screening at age 3. Kids ages 3, 4, and 5 need to have 20/40 or better in both eyes. And if you're greater than or equal to 6, you need 20/30 in both eyes. You're going to refer if there's 2 lines or more difference between the eyes. So next big thing is hearing. In hearing, we start at we obviously have the newborn hearing screen, so those are your ABRs typically. And for your younger kids, we're going to do kind of those risk assessments. But as far as kind of formal screening, you're actually going to start your formal screening at age 4. So keep in mind, blood pressure is age 3, vision is age 3 as well, hearing is age 4. You want to screen annually at ages 4, 5, and 6. And then once you hit that point, then you're going to go to every other year from ages 7 to 12. And then once they hit adolescence, it's really more of a risk assessment, but you definitely want to screen once at 15 years of age. Especially with all the earbuds, et cetera, that people have now, you want to make sure you're definitely doing those screenings and risk assessments in your adolescence. So just to recap again the highlights. Vision age 3 is when you start. Hearing age 4 is when you start. Blood pressure is age 3 when you start. As far as dealing with dental, so dental, it's important to note that you want to have a dental home established by about 12 months of age, definitely around 6 months after that first tooth erupt. So that tends to be closer to around 12 months of age. You want to do oral fluoride supplementation if the water is deficient in fluoride. And there actually is a fluoride varnish program that we use, in PPC and Hopple Street. For high-risk kids, we actually do that for ages 6 months through 60 months. I'm going to spend a little bit of time here on Down syndrome recommendations, and I'm going to focus a little bit more on the next slide. So as far as Down syndrome highlights, as far as primary care, all of your kids with Down syndrome, you want to screen for cardiac defects, and those are kids that should really have an echocardiogram at birth. The thyroid functions, obviously kids with Down syndrome are prone to issues with their thyroid, so we want to do a newborn screen, obviously has the thyroid as part of it, but then we also check that at 6 months, 12 months, and then we actually check that annually. Vision, we like for these kids with Down syndrome to be seen by an ophthalmologist by 2 months of age, then annually until age 5, and then every other year from ages 5 to 13. Hearing, obviously they should have a hearing screen the same as any other child at birth, and then every 6 months until 4 to 5 years, and then they can go annually. The majority of your patients with Down syndrome will be followed regularly by an ear, nose, and throat doctor because many of them have issues with frequent ear infections, etc. But just make sure if this pops up that you recommend that your pediatrician should be doing screening as well for hearing at birth, every 6 months until 4 to 5 years, and then annually as well. You also want to get a CBC, and the main thing you're screening for is myeloproliferative diseases. You're going to do that at 0 to 1 month, and then you're going to do that annually for anemia as well. C-spine used to be a required screen for kids with Down syndrome. We recommend screening for it, but only if clinically indicated, and that's after age 3. And there are particular criteria that you look for to see who actually needs those screens. We used to do it routinely to do the C-spine films, but now it's just really for kids who need that, not all kids with Down syndrome. Celiac tested, same thing. We want you guys to screen for that by history, but we only do the actual labs if clinically indicated. So those are kids that are having weight issues, other GI complaints, because they're definitely as a high risk for celiac disease in kids with Down syndrome. But just screening by history is really the first step at this point. So as far as lipid screening, so there's from 0 to 2, there's no recommended lipid screening. From ages 2 to 8, we recommend a fasting lipid profile if there are certain risk factors. And the different risk factors that we see are relatives who've had a significant cardiac history at 55 years in males, 65 in females. If you have a parent with a known cholesterol disorder or a total cholesterol greater than 240, or if the patient themselves actually has diabetes, hypertension, BMI greater than or equal to 95th percentile, or they smoke cigarettes. I don't know about this. This thing says the child smokes cigarettes. I hope they don't smoke cigarettes at ages 2 to 8, but you never know. Maybe if they're from Kentucky, I don't know. And then at ages 9 to 11 is when we recommend the universal screening, and that can be a non-fasting lipid profile, and that's for kids 9 to 11. We like to do that screening. As far as developmental screening, so we do a ton of developmental screening in our primary care clinics. Many of our kids are obviously really high risk, but as far as AAP, they actually have specific times we're supposed to do these screening. So we kind of do the developmental screening test. Recommendation is 9 months, 18 months, and 30 months. And that's your more traditional developmental screening, kind of looking at your gross motor, your fine motor, personal, social, etc. So typically practices are using tools such as the ASQ, your ages and stages. The autism screening is really done using the MCHAT, and that is done at 18 months and 24 months. And then we really just recommend developmental surveillance at all ages. It's important, obviously, to catch these kids early, and if they have any particular red flags that come up, get them into appropriate therapies. Just remember, the earlier you screen and identify kids with developmental delay, the sooner you get them into therapies and the better the outcome.